Based interventions. Dr. Sharma earned a Doctor of Medicine degree from the University of Western Ontario and a Master's of Public Health from Johns Hopkins Bloomberg School of Public Health. She currently works at the Abdul Latif Jameel Poverty Action Lab at MIT. Welcome.
Thank you very much. Good morning, everyone. Today I will be presenting results from a study on education and HIV-AIDS in Western Kenya. The study is a randomized control trial assessing the long-term biologic and behavioral impacts of two school-based interventions, training primary school teachers to deliver an HIV prevention curriculum and subsidizing education through provision of free uniforms to students. The vast majority of new HIV infections occur in sub-Saharan Africa, where nearly 2 million people become infected with HIV every year. Young people are a key group in HIV/AIDS prevention. They are often referred to as a window of hope because they are uninfected and their sexual behaviors are not yet established and may be more easily molded. About 45% of new infections worldwide occur in youth 15 to 24 years of age, with 3,000 young people infected each day. The majority of these infections are due to unprotected sex. Education has been called a social vaccine for HIV/AIDS. A number of studies have shown a link between school attendance and reduced vulnerability of girls to HIV infection. School-based HIV programming, starting as early as primary school, is also considered an important means to address adolescent risk behaviors. Several factors lend support to this view. First, in sub-Saharan Africa, most children now attend some primary school. Thus, a large proportion of youth can be reached via schools. Second, a number of studies suggest that youth in sub-Saharan Africa initiate sexual activity while of school age. Finally, school-based HIV prevention programs can be inexpensive, easy to implement, and to replicate. However, there's limited rigorous evidence about the effectiveness of these types of programs, particularly on biological outcomes such as HIV and other sexually transmitted infections. So between 2003 and 2006, the nonprofit organization International Child Support conducted a large randomized trial with 328 primary schools in Western Kenya. The study aimed to compare the effectiveness of two programs conducted either in isolation or combined: teacher training in Kenya's national HIV education curriculum and a free uniforms distribution program. The teacher training program involved training 3 upper primary teachers per school on the national HIV curriculum, which had been developed by UNICEF in conjunction with other stakeholders, including religious groups. The national curriculum focused on abstinence as the most effective way to prevent HIV and did not include information about condoms. After adoption of this national HIV curriculum, many teachers remained uncomfortable and reluctant to teach the curriculum. The in-service training provided by the ICS program aimed to address this issue and thereby increase delivery of the national curriculum. The uniforms distribution program involved distribution of 2 free school uniforms to children in sampled schools in order to reduce the cost of education and to keep them in school longer. School uniforms are the only remaining cost of attending primary school in Kenya, and at a cost of $6 each, they represented a significant expense for poor Kenyan families at the time of the program. The study was conducted in Butere, Mumias, Bungoma South, and Bungoma East districts in Western Province. It included approximately 19,300 youths, of which about half were females. This cohort of youth was enrolled in grade 6 in 2003, and they were on average about 13 years of age at baseline. Schools were randomly assigned to one of 4 study arms: the teacher training arm, uniforms distribution program, an arm with both teacher training and uniforms, or the control group. An initial follow-up was conducted between 2003 and 2007. Data from that follow-up suggested that teachers who participated in the teacher training program were more likely to discuss HIV in class, However, there was little impact on knowledge, self-reported sexual activity, or condom use among students in these schools. In addition, there was no impact on pregnancy rates 3 years and 5 years later. Students in schools that participated in the uniforms programs had lower dropout rates. The uniform program also reduced the rate of teen childbearing from 33% to 29% after 5 years. So this current study is a long-term follow-up study to assess the biological outcomes of those two programs. It began in 2009, more than 6 years after implementation of the interventions. The study involved a cross-sectional survey to measure behavioral outcomes, as well as herpes simplex virus type 2 and HIV prevalence. However, the study was not powered to estimate impacts on HIV. So this chart just is a visual representation of the study design. So the main challenge of this follow-up study was in physically locating the study participants. The population under study was extremely mobile. At the time of the follow-up, the youths in the sample had transitioned out of school, and many had married outside of their initial villages. During the first phase of the follow-up, called the regular tracking phase, about 55% of the study cohort were successfully tracked and surveyed. Of the remaining respondents, 29% were sampled for the intensive tracking phase. The intensive tracking phase involved sending enumerators and lab technicians to various locations, including outside of our study areas, such as Nairobi, Mombasa, and even Uganda, to individually track the respondents in their current homes. In total, 77.5% of girls and 84% of boys sampled for intensive tracking were successfully surveyed. The effective tracking rate, therefore, of the study was 89% for girls and 93% for boys. So that basically means that for over 90% of the total sample, we have data on the respondent, him or herself, or on that of a representative respondent. Conditional on being successfully tracked for the follow-up survey, compliance with HSV2 testing was remarkably high at 97% on average and comparable across groups. So here we show the impact of the programs alone or in combination on marriage and childbearing 7 years post-intervention for girls and boys separately. Odds ratios are adjusted for age at baseline, the randomization strata, and the date of the survey and blood draw. Sampling weights were also used to account for the fact that respondents interviewed during the intensive tracking phase were sampled to represent a larger sample of individuals. So girls who participated in the uniforms program were less likely to be ever married. The adjusted odds ratio is 0.810, and that was significant at the 10% level. The reduction in teen childbearing that was observed in the uniforms group after 5 years that I mentioned earlier can still be seen after 7 years. The adjusted odds ratio was 0.84, but it was just above the cutoff for significance at the 10% level. So here, this table shows the impact of the programs on HSV2 infection. The HSV2 prevalence rate, the overall HSV2 prevalence rate among males was 7.14%, and among females it was 11.79%. As can be seen, neither program alone reduced HSV2 transmission. Girls who attended schools where both programs were implemented jointly had a 20% lower risk of being infected with HSV2, and that was significant at the 10% level. The effect is less pronounced in boys attending schools with both programs, and it did not reach significance. So this table shows the impact of the programs on self-reported sexual behavior. We did ask respondents a number of questions related to sexual behavior, including condom use, number of sexual partners, and so on. However, this is self-reported data that is often subject to important reporting biases, and we do see here mixed results that don't necessarily align well with the objective biological markers of risky sex that were presented earlier. Here we see that girls at schools that received the uniforms program were less likely to have more than one sexual partner, which was significant at the 5% level, and boys in the uniform program were more likely to report using a condom at last sex. Boys at schools that participated in both programs were less likely to have ever had sex. So in conclusion, the provision of educational subsidies in the form of free uniforms appears to be effective at reducing dropout rates of boys and girls and teen childbearing and marriage rates among girls. However, the uniforms program on its own did not reduce HSV-2 transmission. The Kenya National HIV curriculum focused on abstinence until marriage seems ineffective at reducing HSV-2 transmission. Both programs implemented jointly appear to reduce HSV-2 transmission, and the effect was more pronounced in girls than in boys. And just a thank you to all the youth who participated in the study, to my co-authors, and to our partner organizations who were very supportive. Thank you very much.